Ladies and gentlemen, thank you for attending the SIH EMS Stroke Seminar tonight. I'm coordinator for Southern Illinois Healthcare, and I want to welcome everybody. And it's usually not hard for healthcare providers, specifically in EMS, to find the food, but it's in the back, and I think everybody's found it. So thank you for coming and participating tonight, having a chance to learn a little bit with us. And thank you to those out in cyberspace that are joining us remotely via webinar as well. So at this point, besides thanking everyone for being here, taking the time out to learn a little bit more and become a little more well-versed in stroke recognition and treatment, I also want to recognize two of our sponsors that helped make dinner possible tonight. That's Genentech and Medtronic. So we thank them very much for what they've done to provide dinner tonight. First up tonight is Dr. Alejandro Ornick, who is a neurointensivist and the director of the Stroke Network for Southern Illinois Healthcare. So if you would join me in welcoming Dr. Ornick.
Hello, can you hear me? Is this working? Oh, it's recording for the webinar. Hello, webinar. You may want to activate the accent correction system. Do you have it? All right, is there? All right. I need 10 volunteers to stand on the food table and block the sun. If you ever thought that I was going to read the slides, I am toasted. All right. So this is, what do I push for the laser? Oh. So this is the first time. This is the first time for many things that are happening tonight. So I am very excited. Our team is very excited. We have a stroke network that means much more than a bunch of hospitals working together. That has been taking care of stroke victims and our community for over a year now. And this is changing the way that we are treating stroke in the region. And we hope to believe that this is also changing the outcome of those patients. This is the first time that we are getting our stroke patients together with our EMS providers because of many reasons, but more than anything because we think that this is an amazing opportunity to talk, to meet each other after that initial terrible few minutes in which our well-trained techs are doing their job and our patients are wondering what's going to happen to them over the next few hours, days, and months. We thought that getting together a brief lecture, a symposium in which we can update you on some information, we can get to see our faces, and more than anything, we can open the forum for any questions that you may have, and then we do this again, and then we do this again, and then we do this again, and then in a few years, this will be normal. Getting to meet your patients, getting to know what happened to them, getting to know their families, it's going to be hopefully normal, and this will be hopefully the first time this ever happens. So to all of us, this is an amazing day. Our team usually counts how many times they say amazing every time I talk, so we are 3 so far. So the objectives of my brief lecture will be to talk about what happens to our patients that are having strokes, what are the common signs and symptoms of stroke, and what are the called stroke mimickers. In other words, what else could be going on with our patients when we think they're having a stroke but they're not? Then we'll talk about what should we do with those patients and what should we not do. And then I'll give you a very brief perspective of how the future will look like in our day-to-day stroke care and what are we doing in Southern Illinois to be part of that future. So if I tell you that signs and symptoms of stroke is summarized by the sudden loss of focal brain function, then I'm summarizing everything I had to learn through the 13 years of training, right? So if I tell you this is it, if you have a patient that has sudden loss of brain function, you know that they could be having a stroke, right? So obviously this is not that easy. I try to have this to come out flashing up, and my PowerPoint skills are horrible, so it showed up at the same time. So we know that many different tools have been developed with time trying to make people aware of what a stroke is and what it looks like, right? I always say the same thing. 40, 30 years ago, if you had chest pain, crushing chest pain, you thought that you were very sad or very tired and you went to bed and you were lucky if you woke up the next morning, and if you had short of breath with it, you may end up in the hospital with a very, very large nitroglycerin drip, and maybe you would get a cabbage. Now, everybody that has chest pain is rushing to call 911 because they know that chest pain is most likely a heart attack, and they better do something very quickly so that they can go back to work 2 days later with a normal-looking heart. Well, we are it. We are the cardiologists 30 years ago. We're trying to convince our patients and our community that if you are having facial asymmetry, if you're having new onset arm weakness or leg weakness, or if you're having difficulty talking, then you must call 911. You should not call your significant other, your primary care doctor, your chiropractor, your neighbor who watches ER. You should just call 911, right? Every example I'm giving, although it's funny, I promise that we've had pretty much every week, right? And there are scores and there are scales trying to train our EMS providers to recognize stroke symptoms and to try to put priority in them, because while we're all meeting right now and talking about stroke, and we have a pretty large rural stroke network, most parts of our country still do not prioritize brain injuries as an emergency, but they think that it is the same as it was 30, 40 years ago, in which nothing can be done. So this is an example of the Cincinnati stroke scale. I always say that the pointer makes you aware of how anxious I am because of the shaking, so I apologize. But the Cincinnati stroke scale is the one that probably most of you are using now to assign some score to your patient and try to understand, is this a stroke, is this not a stroke? So what I'm going to do right now, if you can see this maybe with sunglasses, I will try to make your life much more complicated than the Cincinnati and the fast screens. And I will try to tell you that if any of your patients have sudden problems with any of these things, it is very likely that they're having a stroke, or at least you have to assume that they are until proven otherwise, okay? So here we go. I only have a few minutes, but if somebody has new onset cognitive function problems, i.e. sudden forgetfulness, okay? If suddenly they can't remember what they're being told and they're asking over and over again, okay? Not grandpa or grandma who have been asking over and over again for the last 6 months, 2 years, but if suddenly somebody says, hey, where are we going? To the store, honey. Oh, okay. Where are we going? To the store, honey. And this every few seconds, then this could be a stroke. If somebody has sudden onset of cranial nerve function deficits, this could be a stroke until proven otherwise. Half blindness with each eye, full blindness with one eye movement problems, or in other words, double vision, right? Double vision, you close one eye, it goes away. You close the other eye, it goes away, but you have both eyes open and you're seeing double. This could be a stroke. If you can feel half your face, if you can move part of your face, if you suddenly cannot hear on one side, if you have sudden difficulty swallowing or moving your tongue, if you have speech problems, right? Speech problems refer to mechanical problems with your speech. either because you can't move your tongue or you can't move your face. If you have language problems is not what I have right now, this is called an accent, but language problems is when you can't repeat, when you can't comprehend, or when you have no or decreased fluency, right? And I wanted to pay special attention to these two, and I'll give you a few examples on how this could really get all of us talking a different language. If you have limb strength problems or weakness, right? Or if you can feel half your body on one limb, if your patient suddenly starts walking like intoxicated but they didn't drink, right? Or if you have sudden onset of vertigo. Vertigo meaning spinning sensation or sudden tilting, right? The world is suddenly tilting. So I'll give you some examples. These are straightforward examples, but are very not common, okay? These are very common on the books, but they're not very common in the ER and in the world that we live in. 65-year-old with new onset right-sided weakness and numbness and difficulty talking. The left brain is not working very well. 56-year-old with new onset vertigo and double vision, all right? So suddenly everything is spinning and they're seeing two of things. 19-year-old that suddenly gets blind and can't talk. Okay? Very good. So these are very common examples that are absolutely non-straightforward. So I will tell you this and you will think that you've seen this probably every week, but you don't see this every week, right? Or at least you think you don't. So a patient with altered mental status, a patient with confusion, a patient with dizziness. Unfortunately, for us, for the brain specialist, altered mental status means like tummy ache to a general surgeon. It doesn't mean too much. It could mean many, many things, and it could mean nothing. Confusion, same thing. Dizziness could be lightheadedness, vertigo, and steadiness. So if your patient has a very low blood pressure and they stand up, they will feel orthostatic or they will feel lightheaded. If your patient has difficulty walking because they have an ankle problem, they will be unsteady, or if they had too many whiskeys. Vertigo is the sensation of spinning, okay? If you can't understand language because of a stroke, but you can talk and your talking doesn't make too much sense, and you're not aware that you can't understand language, functionally, if you tomorrow wake up in Japan and you look Japanese and your whole family thinks that everything's normal, then you could be having a language problem, but people will think that you're confused. What does confusion mean? Does confusion mean disorientation? Does it mean that they're inattentive? Does it mean that they're sleepy? So all these things we try to categorize in a meaningful way to try to build together a neurological syndrome. And just naming these things to you may help you tomorrow when you're listening to the family member, try to understand, what do you mean Grandpa was confused? Did he not know where he was? Or you can't understand anything he's saying? Or what he's saying makes no sense? Did you try to tell him to do something and they didn't get it? Sir, can you show me two fingers? Without showing the two fingers so you don't use mimicry. And then the person, when you ask them to do this, they're like, blue, my shoe is blue and there's a flying cow. And you're like, okay, the patient cannot get any language, right? So you're trying to categorize all these different things. By the way, the more, I don't know how much you can see off the screen, I'm so sorry. But the more of this that you group together, the higher the likelihood of your patient having a brain problem, right? If they cannot see with half eye and they're seeing double and they have difficulty talking and the face is weak, you see, it becomes much easier than just having double vision and nothing else, right? So the more of the functions that are dysfunctional, the easier it is to diagnose the patient. So what is, I am getting ahead of myself. What is going on to the patient? What is an ischemic stroke? An ischemic stroke means lack of blood flow to a cerebral territory, to a part of the brain, right? And why would this be going on? because a small blood pipe shut down, because a large blood pipe shut down, because the inner wall of a blood pipe is ill and is dissecting, because there is a clot that is coming from a different part of the body, most likely from the heart, also could be from another artery, could be from a vein. A patient was flying coach from Shanghai, arrived to Chicago, stood up, such a long flight, weak on the left side, clot in the leg, through the heart, to the brain, cannot move the body, right? So these are different reasons for a patient to have an ischemic stroke. The general population and the non-specialist, you also refer, utilizing the word stroke, to brain bleeding, and we're not talking about brain bleeding today. We're talking about lack of blood flow to the brain, right? So what else could look like a stroke? Well, number one, a brain bleeding. Unfortunately for you and for us and for anybody, there is no way when you're seeing a patient to know if a patient is having brain bleeding or lack of blood flow to a chunk of the brain. A few things help. Number one, 85% of the patients who are having a stroke are having lack of blood flow, and only 15% are having a brain bleeding. But honestly, you can't tell. And that is the only reason why we get a CAT scan. That's the only thing for why we get a CAT scan emergently. The CAT scan is to make sure the patient is not bleeding, not to look for the stroke, right? A normal CAT scan never rules out an ischemic stroke. It's only to rule out, most of the times, the bleeding. And then you can have very low blood sugar, very high blood sugar. You can have a brain infection. You can have an infection in anywhere in your body and a prior stroke. Stroke 5 years ago, UTI. Suddenly my old stroke symptoms are coming back. UTI gets better. My stroke symptoms go away. High sodium, low sodium, renal failure. You can have a migraine equivalent. Sometimes auras are not just seeing flashing colors, but being unable to move half your body. You can have a seizure that looks just like an ischemic stroke. You can have a conversion disorder. This is not to be minimized. You can have a patient that is going through tremendous psychological trauma in their life, who are profoundly ill, and their only way to ask for help is being unable to move half the body, right? And this could be the way that we see these patients. You can have a patient that suddenly forgets everything that they're hearing, and that's called transient global amnesia. You can have unlikely multiple sclerosis or brain abscesses or brain tumors. So what do you do when you get a patient like this? Well, the goal is that you try to get the patient the safest and the fastest to the nearest stroke facility, okay? So you are probably among the most important things that we need to be able to help our patients. Why? Because 95% of what we're going to do on the initial 5 minutes is going to be based on, number one, the patient being there on time. Number two, the patient being there on time. And you can guess number three. So the first thing you could do is you could let the stroke team know that you're bringing a stroke patient, because we are going to drop everything we're doing, or plan to drop everything we're doing, and be ready to respond to our ER doctors if they need us with a stroke victim. Number two, we need to establish the last known well. Okay? We mentioned about the need for the CAT scan, that will be taken care of the ER most of the times. Okay? And obtaining the last known well and availability of data that would let us see if the patient has any exclusion criteria for TPA is super important. And you guys usually are gathering this without even knowing that you're gathering this, right? So this is our latest list of inclusion-exclusion criteria that we're trying to obtain at the bedside of a patient who can't talk. Okay? So we're trying to go through the yes and no's on this in usually no more than 5 or 10 seconds with a patient that is usually very anxious, and if we're lucky, the patient can understand language, right? So you can start understanding how interviewing the bystanders is critical, and getting data from what really happened to the patient could make the difference between life and death and outcome on a patient. And usually the only ones that know exactly what happened and why they were called is you. So when you are taking care of the patient in the pre-hospital care, never forget, of course, I don't have to tell you this, about the ABCs. I do have an editorial here. Don't forget that our patients either can't talk or can't feel, for what is always safe to assume that they could have some cervical spine problem until proven otherwise. They may not have the neck pain if they fail, or they may be unable to tell you that they fail and they have neck pain. So usually we see that these patients may have injuries that are underdiagnosed in the cervical spine, right? Weakness, fail, but can talk. And if you ask, do you have neck pain, you won't know. And if the family was able to help them out, you may not think that they really took a fall, because they may be taken care of in a way that is distracting, right? So if you can identify, and maybe if you can reverse any exacerbating conditions, you know, the patient is down next to an insulin syringe, maybe the patient is hypoglycemic, the patient is down next to a syringe that usually is not labeled as heroin, although you're getting more and more experience with this, then you may be able to identify the condition and reverse it. If you come across medication lists, it is crucial for us that you bring them with you. If you, I don't know if I'm allowed to say to bring the medications or not. Am I allowed? Try to bring the that's what I wrote, borrow, so we can bring them up. So if you can borrow the medications, this could be life and death for the patient. Why? Because back in the days, 15 minutes ago, all patients had was Coumadin, right? So we check the INR, we know if you're taking blood thinners or not. We move on, nobody thinks about it. But now we have apixaban, rivaroxaban, dabigatran, xarelto, you know, you check the usual blood work available at normal non-academic hospitals, it's all normal, and we're giving clot-busting medications to patients that are on very strong blood thinners. So you bringing those bottles may mean the difference between life and death to the patient. Getting the initial history, last known well, getting the witnesses, if you can borrow the witness, can they borrow the witness? Please borrow the witness, you know.
They're willing to go, yes.
All right. I usually use chocolate. In emergencies, chocolate works fine. You tell them, if you want some chocolate, please come in the ambulance with me. And you're bringing this is crucial, because you don't understand how many times we're trying to, if you have the patient's cell phone and you can bring that cell phone, we're trying to look on the cell phone. When is the last time this patient made a phone call? Could the patient text? Who did they talk with? What did they talk about? We're desperate trying to find the reasons to give clot-busting medications. So all these things are critical. So can somebody tell me what does the last known well mean? Exactly, right? So we do not use, usually, we do not use time of onset, because that becomes very confusing. We use last known well. When is the last time that the patient was normal? And this is not a problem. This is very straightforward. And people usually become afraid of using this, because one perfect answer is we don't know. And that's fine. When we say we don't know, we don't know. And if you are receiving care in a different facility, and as data, gets better and we become better at what we do, we have alternative imaging, and we can even treat patients regardless of the last known well. But for most of what we do here, we need that last known well. And when we know that we do not know, hopefully the webinar, they got that one, the last known well, that is very safe, because we are going to decide to be careful and avoid treating that patient with medications that are very dangerous. But if you establish the last known well, and the last known well is within those 6 hours that we need, sometimes even 24, this will allow us to be very aggressive with these patients and utilize all these therapies and all these clot-busting techniques that I'll mention about. So the last known well is the most important part of the story. What does the last known well usually get confused with? The time of me finding out what happened to the patient, okay? I walked in the morning and I found grandma on the floor and she couldn't move the right side. I talked to her at 8 p.m. I walked in at 9 a.m. the next day. Time of onset, 9 a.m. No. Last known well was 8 p.m. Maybe grandma made a phone call 2 hours before you saw her. Let's look at her cell phone. The patient is on a nursing home. He went for lunch. He had lunch just fine. Went back to the room. Didn't come for what happened for dinner. You know, we went to the room. He couldn't move the right side of the body. We found him at 7 p.m. Last known well when they went to lunch. Nobody saw them in between. We don't know exactly what happened. We can start thinking what happened, but the last known well is the last known well. And that is the most important piece of information that we use with the inclusion-exclusion criteria. What are things that you should not do? You should not use blood thinners. And you never use blood thinners, but it's very common that we hear the story, I had right-sided weakness, my mom or my sister or my cousin called 911, and they gave me 2 aspirins. And usually you're walking in and the patient is taking the 2 aspirins. That is taken from the cardiovascular literature, and unfortunately, because we don't know if the patient is bleeding or having lack of blood flow to the brain, if they're bleeding and they take those aspirins, they can make things worse. So we do not use blood thinners until we get that initial CAT scan, okay? Losing contact with witnesses, that extra second that you will take in writing down the cell phone of the person that was with you or in offering the chocolate to bring them to the ambulance, that could make a huge difference in what's going to happen to the patient. You have no idea how many times we know that this is within window, but we can't prove it. And this is, you know, very, very difficult for us because we're trying to help these patients. This is a phrase that trying to avoid using the wrong hospital. There's many protocols and algorithms, and this is changing state by state, county by county. But I want to try to convince you, and by the way, please interrupt me with questions at any point, and any of our speakers, if you have any concerns of what you're saying, or doubts, or please ask us. But there is a strong change in the way that we're treating ischemic stroke and bleeding patients in 2016 and in America. So there are hospitals that are qualified to take care of these patients in a way that is significantly different than others. And we'll talk about this. And when you take a patient to a hospital that doesn't have the capabilities of dealing with these patients, by default, we are delaying the care of this patient until the patient gets somewhere else, or we're exposing this patient to a care that is different than what he could be receiving in a different place. Okay, and we can talk about this a little later. So what do we have to offer? We have to offer 24/7 bedside or telepresence availability of stroke-trained neurologists. Okay? We can evaluate the patient. We have state-of-the-art neuroimaging that has nothing to envy to large academic and medical centers. And we can have immediate decisions on site about the utilization of reperfusion with IV TPA, and not or, you always think of TPA first and you never delay TPA, and considering thromboembolectomy. That means taking the patient to a center in which they can poke the groin, go up through blood vessels to the brain, and bring the clot out from the brain. But TPA is always the most important decision and the one you have to make the fastest. Okay? These are just brief examples of what we have to offer. Of course, we have 24/7 MRI. We have conventional angiography. We have CT angiography. We have CT venography, MR venography. We have diffusion-weighted imaging, assessment of MRI. In other words, we have CT perfusion coming up very soon. So we have everything that any large center is right now utilizing as standard of care to treat patients with ischemic stroke out of research. What is reperfusion therapy? Okay, so if a patient is having lack of blood flow to a chunk of brain, the best proven therapy we have is to put an IV and to give clot-busting medications that are systemic. And we can do this up to 4.5 hours from last known well. We have also the possibility to identify in our center which patients could benefit from thromboembolectomy and take them to the appropriate facility to receive this. Also, patients can receive TPA inside the very artery that is shut down inside the brain. These two we do not provide on site, but we are able to scrutinize and decide who needs to get it and who doesn't, and who could benefit from trying to get it and who wouldn't. And in a rural area where it takes more than an hour to get to a table like this, this could mean the difference between somebody going to get a life-saving procedure or somebody just taking a 2-hour ride by helicopter to receive exactly the same care they could receive here and have the family visit in a 4-hour commute every day for a few weeks. So this becomes a big deal. And we have on-site the ability of opening up carotid arteries, and you'll hear more about it a little later. So this is my last, or the one before last slide. This is the future, and the future is no longer the future, but the future is happening right now, okay? So right now, anybody has an ischemic stroke within our region and calls 911, and 911 takes the patient to one of any of our hospitals belonging to the stroke network, and within seconds, the doctor is usually not so good looking. It's actually me or Dr. Golombiewski, but within seconds, something like this shows up at the bedside, and we are examining the patient. So you have 24/7 availability of stroke-trained neurologists right now in 8 hospitals in the region. Okay? So this did not exist months ago. And this is already happening, and you're going to meet today patients who already had this treatment. Now, we do not have this, but if any of you have $1.5 million that you're not using, if all of us get $10, we will not even get to one of the tires. Right now, there is 2 in the country, but I am sure that I will find out somebody that is going to be nice enough with us and will get us one of these. Do you guys know what this is? So this is a mobile stroke unit, okay? This is super cool. Nothing else to say. So in a rural area, you're calling for a code stroke, and the hospital goes to your house, right? All the good part of the hospital, not the bad part of the hospital. So you get here an ambulance with stroke-trained EMS personnel, with either a doctor on site like Texas, or, I don't know if you can see it, a tiny computer up there with telemedicine in the ambulance. So you park at the patient's house, or you park at the rendezvous between the patient's house and the stroke mobile unit, because an ambulance could make it faster, and we all park in Starbucks or Arby's or whatever, and you are providing the initial evaluation of the patient, and you're doing the door-to-needle time becomes 3 minutes, 5 minutes. Right now the goal is what? Where is Daniel? Less than 60, less than 90? 60? Okay, so we could do this to 3, 4 minutes. You can identify a patient that has a subarachnoid hemorrhage at their doorway, and you can fly them to a center that is able to deal with them without having to do all the steps that you all know what happened to a patient that ends up having to be flown. So this is happening right now. This is a picture of the ambulance with the scanner. If you get $1.5 million, that's not the value of the ambulance. That's the value of the ambulance with the scanner and the salary of the whole crew for a few years. Okay? So, and you can get this running, I believe, for 5 years. There's a paper from Dr. Grota that specifies everything you need to take this. So hopefully you'll be seeing this in our future. This is amazing, right? So these are the names of all our team members, and I wanted to be thankful to each one of these people that you're seeing here, and I wanted to be very thankful to you, because you are the ones who are making the difference, and making sure that we meet and we talk, and you meet us and we meet you, and you meet our patients and we meet your patients is going to be the best way that the care of stroke in Southern Illinois will continue improving and improving month after month, year after year. So thank you very much. Any questions? All right, very good.
The question was, what were the 8 hospitals? And Danielle's going to go over that in her next presentation. Okay. So next is our lead stroke coordinator for Southern Illinois Healthcare. Her name is Danielle Short. And give her a big warm welcome.
I'm going to make this short and sweet. Get on to the more interesting people. I'm surprised that Dr. Ornick hasn't started his own lemonade stand or bake sale to get this mobile stroke unit as much as he loves it. But all right, so first I wanted to thank you all for everything you guys do, not just for stroke patients, but all of Southern Illinois. I know we have a lot of challenges, especially because we're so rural, but what you guys do is amazing and really touches our whole community, okay? So thank you. Who is in the stroke network? We've grown quite a bit in the last year. We started this a year ago in May. There's 2 hub locations. This is Memorial Hospital of Carbondale and Heron Hospital. Between these 2 locations, we have many ICU beds and stroke units so that we can be taking all those patients from the stroke network hospitals. The spoke locations include St. Joseph Memorial Hospital in Murfreesboro, Harrisburg Medical Center in Harrisburg, Hamilton County Memorial Hospital in McLeansboro, Marshall Browning Hospital in Du Quoin, and Pinckneyville Community Hospital, and then Franklin Hospital. I've gotten the opportunity to work with the nurses and ED physicians in these facilities and give them the education that they need to be able to take care of those stroke patients that you are bringing into them. So it's very exciting to get to give you guys some education as well and to let you know what we're doing in the community. So I'm just going to be reinforcing some things that Dr. Ornick said earlier, but the question is, what is your role in the stroke network? And you guys have a very important role. You guys are the first people that touch the patient. You guys are the ones that gather that initial information that we might not be able to get otherwise. And you're the ones that are going to get them to the hospital very quickly. So it's very important that if you suspect a stroke at all, that you go ahead and pre-alert that hospital. Because what happens, regardless of any facility that it's in, out of these 8 hospitals, when you pre-alert the hospital, they are going to call into our facility, and we're going to send out a page to the important people like the neurologist so that they can be ready once that patient arrives to the hospital and has, sorry, that's me, I'm up here playing with the cord, and has gotten their CT, okay? We know time is brain, right? The other important piece is that you take them to the right facility for our EMS protocols. If you haven't looked at the stroke protocol, take a look at it. There's good information in there. We want to take them to the nearest stroke facility that's able to take care of them. We want to make sure that we're all performing the Cincinnati stroke scale. This puts us all on the same page. So if we're all looking at the face, the arm, the speech, then you're able to give that report to the nurses, and the nurse can relay that to the physicians with what's going on, okay? And then gather that other important information. I know Dr. Ornick hit it hard, but the last known well is so important so that we know if this patient's going to be a candidate for TPA or for possibly a thrombectomy. And then that medical history. So what happens once they arrive to the hospital? If they arrive to one of our stroke network hospitals, I love this picture. This is actually during training, but we'll take Dr. Ornick anytime we can get him. He had to pull over on the side of the road, so that's why he's in his sunglasses. Gotta do what you gotta do. So if you bring them to one of the stroke network hospitals, they're going to get one of these guys that are stroke certified neurologists. So we have Dr. Golomvieski, and then you got to see him for quite a while. So thank you again for all that you do.
Okay. Thank you, Danielle. Our next presenter, most of us in the room know because to some capacity he's our boss, and if he's not, you've probably run into him in the ER if you work through another system. But Dr. Joseph Hake is an emergency physician, and he's the EMS Medical Director for Southern Illinois Regional EMS. and he's going to go over a couple of cases for us. So, Dr. Hake.
All right, thanks for having me, and thank you all for coming. I know we're all very busy, and I really appreciate everybody's willingness to spend your free time here with us this evening. It's really important. As Danielle and Dr. Ornick have mentioned, you guys truly are the front line for acute strokes, and you guys really do make a big difference in how these patients can be treated. I can't reinforce that enough. Every bit of information you gather, every piece of your assessment that helps us enact the events that occur in the ED and once on their inpatient side truly makes a difference in patients' lives. We're going to highlight that here this evening with two patients in particular. I'm going to go through some brief presentation details about how these two clinical instances occurred, and then we're going to expand from there. So let's jump right into it. Patient number one is a 66-year-old female with a history of atrial fibrillation on aspirin, but no anticoagulation. Last seen normal at the dentist at 9:20. An office clerk recognized left-sided facial weakness, difficulty talking, and difficulty using her left hand. 911 was activated. The EMS team, which was Mike Burford and Crystal Vineyard, gave an assessment of a blood sugar of 108, normal BP of 121/65, heart rate also normal at 63, respirations at 16, O2 94%, and a rhythm of atrial fibrillation. Their Cincinnati scale did reveal positive left-sided facial droop and positive left-sided weakness. Upon ED arrival, the NIHSS was scored at 18. Vitals hadn't really changed much. They did note, however, a normal sinus rhythm. CT non-contrast of the head revealed a right dense MCA sign that was longitudinally extensive. The exam revealed left homonymous heminopsia, left hemiparesis, and sensory loss. The platelets were 223,000. The INR was 1.03. At this point in time, there were no contraindications for TPA. The bolus was started at 11 a.m. Dr. Hornick, did you have a comment about this? Is the non-contrast head CT.
So here you can see on this axial cut, no contrast head CT, that this is the cerebral artery on the right side. So this is the middle cerebral artery on the right side, and this is the middle cerebral artery on the left side. You can barely see the one on the left because it has the same density as the adjacent brain tissue, but you can see clearly the one on the right, and this is called the dense MCA sign. This tells you on a CAT scan without contrast that it's very possible that this patient is having a thrombus or a shutdown that is fresh. So this artery just shut down. And the beautiful part of this CAT scan is, as we were highlighting earlier, the brain tissue is just fine. You will never find an acute stroke in a CAT scan, right? You're looking for bleeding, but this one helped us find that there is a thrombus.
So the patient was ultimately transferred to Barnes-Jewish. A CT angiogram confirmed that this was indeed an MCA occlusion, as that previous non-contrast CT revealed, and the patient was taken to an endovascular suite and had a successful thrombectomy.
We have Crystal here. Okay. Mike was unavailable today, but Crystal is here. So, yep, Crystal, Mike Burford and Crystal Vineyard were the EMS crew that responded for Donna. Donna and the crew that recognized there was a problem and got them to the hospital. Would you like to say a few words?
Well, yeah, Crystal, thank you so much. I have to present this to you.
Well, thank you.
It was
Get help.
I don't remember a lot of it. Was I okay? I went down in my dentist's office, and the only thing I remember was my hand sliding down the wall. And they scooted his stool underneath me because he said, I've got you, I got you. And I remember Dr. Iron, Dr. Ornick, I remember him, Dr. Harrisburg Medical Center, and I was the first patient for telemedicine. They just installed it on Monday, and on Wednesday I had my stroke. And I have Bell's palsy, so I talk funny. Anyway, I can remember you talking about Lawrence Hospital and going back and forth. And the funny thing is I do remember asking you about the shot. I took it, and I just told him, don't cut off my bra. My sister teases me because I kept saying, I just bought it, it's brand new. I spent $56. And I don't remember the helicopters, anybody here that flew me, the only thing I remember about that is I had on they prepped me, I had a catheter, and a hospital gown, and I told them to shut the door because it was awfully breezy inside. I remember that. And I remember when we landed in St. Louis, I remember that paramedic, I guess, is that who's with you? I don't know who's with you. Whoever was with me, anyway, just said, you're not going to ER, we're taking you right into surgery, they're waiting for you. And don't be afraid, there's going to be a lot of neurosurgeons running around. And so I don't remember any of that, other than they said you're going to feel a lot of pressure in your groin. And then the surgeon, after I got out of recovery, came out and he, what's your name, do you know where you are, and all that. And then he said, do you believe in a higher entity? And I said, yes, I do. He said, well, the good Lord's been with you all day long for all this to happen so quickly. And that the weather was good, they could fly you, and that you were able to have telemedicine. He said all these great things. So thank you very much, because I wouldn't have made it without y'all.
Thank you very much. For the second clinical scenario, we have a 45-year-old female. Approximately 20 minutes prior to arrival, there was an onset of the face looking funny, at which the son noted, at which time 911 was activated. The EMS crew from Jackson County Ambulance Service was Ben Cripps and Jessica Terry. Their initial assessment revealed a blood sugar of 123, Glasgow Coma Scale of 15, a BP of 121/72, heart rate of 77, respirations at 14, and 98% on Romer. Their Cincinnati pre-hospital scale revealed slurred speech and left-sided weakness. The code stroke was called to medical control at 15:14. They arrived 16 minutes later at 15:31. NIHSS on arrival was 21. BP still normal at 112/70, heart rate at 7,100% on Romer. ER's non-contrast CT of the head revealed no hemorrhage and a possible right MCA thrombosis, as we saw the last time. The CTA this time revealed occlusive thrombosis within the distal right MCA. The thrombus arises within the distal M1 segment and extends into the right M2 segment. The labs showed a PT of 10.4, INR of 0.9, and PTT of 25. Those are essentially normal coagulation studies. The exam revealed left homonymous heminopsia and left hemineglect and hemiparesis. There were no contraindications initially found for TPA. The bolus was started at 16:10. Door to needle time was 39 minutes, which is outstanding. This is why what you guys do in the field is imperative. That is not possible without pre-hospital activation. NIHSS following TPA administration was 2. It was 21 on arrival. Dr. Ornick, do you have comments about the CT angio here?
This is a CT angiogram, so this is a CAT scan with contrast that is focusing on the blood pipes on the head. And you can see, it was hard for me to put everything in one picture for you to appreciate, but on the left MCA, you can see contrast filling all the way. On the right MCA, you can see contrast filling with an abrupt cutoff, right? So this is where the clot starts, and this clot went all the way, if this would be the other one, all the way like this and like this. So this was a huge clot. These clots are unlikely to just dissolve with TPA, and these clots usually need somebody to go and finish the job, either by taking them out or by giving more TPA inside this vessel. So the fact that the NIH changed so quickly, while we all want to be optimistic and think that it was the TPA, we were still concerned that this was other factors, and you'll hear how the story continues.
So ultimately, the patient was transferred to Barnes Jewish Hospital for possible thrombectomy. However, due to drastic improvement, no further intervention was pursued. Patient number 2.
This patient, the patient number 2 on the ambulance is Ben Cripps and Jessica Terry. So if they would come up. Would you like to say anything?
Yeah, of course. I also don't remember you guys at all, so I'm really sorry about that. I thought it was some guy named Mike and another guy that...
Story of my life.
But I think it was 2 guys that drove me to St. Louis, so maybe I was more coming around then. So I had meant to thank you a long time ago, so I'm sorry about that. So I was in the bathroom, which is not how you want to go down, but that's how it went. And when you're a mom, you don't usually do that alone. So I had my little 6-year-old who apparently thought that I was speaking in German, was his assessment of the situation. So he went and got my older kids, and then we called my husband at work. And I guess I was literally laying on the bathroom floor, and I'm a family practice doctor, so I told my son, said, I'm not having a stroke. I'm like, just stand me up so I can see myself in the mirror, because my glasses had broken, so I couldn't tell if my face was drooping. So this is the crazy thinking that I'm having, that of course I'm not having a stroke. I'm just on the floor in the bathroom. I'm not sure why, but I'm sure it's fine. So thankfully these guys navigated our driveway, because it was a very snowy day in February. And but still not for very long.
They still made the time.
Yeah, obviously. So so that's just incredible. So I was very, very fortunate. still don't really know where that came from, but yeah, and so then we're doing the testing in the ER, and Dr. Aflac was there, and I just remember them talking about the TPA, and I said, yeah, bring it on. Can't go around like this. But I really wasn't aware of what was happening, which was something that I learned a million things from the experience, but that I wasn't aware of how powerful that can be. Apparently they were telling me to lift my left arm, and I would just lift it with the right hand. As a doctor, you've got to pass the test. So I was like, this is fine. My arm is fine. What's the problem? But all these people came together and literally, returned me to a normal life, and I'm just so grateful. So you guys are really out there in the trenches, and you do a lot for me, obviously, but also for all the people that I try to take care of. So thank you so much.
Thank you, guys. Okay, thank you very much. At this point, I'd like to introduce Dr. Raed Aldallo, who is an interventional cardiologist, and he's going to discuss the role of stents in carotid artery revascularization. So join me in welcoming Dr. Aldallo.
Thank you. Good evening, and thank you guys for having me. First of all, before I just go into the topic of the talk, I'd like to congratulate all of you on getting to this point. I can tell you that a few years from now, you will all look back at how things started in the stroke network, and you won't believe the impact that you made on the communities you live in and the communities you serve, in terms of what does this program mean to all the smaller hospitals around, where not only for stroke, for a variety of other illnesses, their ability to serve their patients is rather limited. And now it's faster and easier to transfer a patient with a stroke and get the proper care and get them back on their feet within a day or two, say, than to treat some of the even more common issues like a really bad pneumonia, for example. So just give it a few years, and I promise you, you'll look back and you just won't believe it. You'll just look at the data, the numbers, and the number of lives you've touched, the number of things you've changed in the community hospitals, and you just won't believe it. So anyways, what I'm going to talk about, I'll spend the next 20-25 minutes, I'll try to keep it short, is carotid disease and carotid revascularization. And, strokes have a variety of etiologies. Some of them are hemorrhagic, some of them are embolic, and those that are embolic could come really from anywhere. But what I would like to focus on is this last thing right here. So about 25% of the embolic stroke happen because of a problem right here in the carotid artery. So, some embolic stroke come from the heart, aortic arch, common carotids, etc. Other places from a DVT like Dr. Ornick had just mentioned. But 25% of them originate from the carotid bifurcation. And why is that important? Because the carotid bifurcation is right here. You can monitor, screen, and discover disease in the carotid bifurcation literally years before it can become a problem. And what do you do with it before it becomes a problem? Technically, it's intense medical therapy, the same stuff we give for blockages everywhere else: aspirin, other blood thinners, statins, or any method to lower the cholesterol. Or if anything, just telling the patient that they actually have a blockage and now it's time to act on it. So how does a carotid disease cause a stroke? There are a few ways. So imagine blood flow has to go in this direction. And if you have a really tight blockage, there are few ways in which that blockage can cause a stroke. The most common one is you get a little piece of either a plaque, which is what we call atherombolism, or a blood clot, which is thromboembolism, that just goes up, and then it would lodge in a smaller blood vessel, either the anterior or the middle cerebral artery, and then it causes a stroke. The other way to do that, which is fortunately very rare, is for the plaque to rupture and cause a complete thrombosis, and this whole thing shuts down. Unfortunately, it's very rare because your upstream will affect all the branches. So complete carotid occlusion as a cause of stroke is a very dramatic stroke, but it's uncommon. The other way is if the circle of Willis is not complete, not having pressure beyond that point, it's a gradient, right? So when I block my own neck, I cause a gradient. So if my systolic blood pressure is 120 and I block it, it'll be 60 here. Imagine if someone's systolic blood pressure is 60. Is that what the brain is seeing at that point? So a variety of ways. And then the other category here, which I will really kind of leave alone, but I just put it down to kind of get you're the first line, and if you get a phone call about a 19-year-old college kid who can't talk, stroke is not the first thing that comes to your mind. It's not very common in that age group. But I want you to always be mindful that there are diseases that are actually common in the young people. So fibromuscular dysplasia, what we call non-atherosclerotic vascular disease, meaning blockage is the most, atherosclerosis is the most common form of vascular disease, but there are other congenital things that actually manifest in young people. So if the symptoms and the clinical picture that the previous speakers have alluded to fit, don't let the age kind of distract you from diagnosing a stroke in a 19-year-old. It is a stroke if it sounds like one, if it looks like one. But then it is our job now to find which kind of odd doc is causing that in a young person. This is the most common. So when we do an angiogram or a CTA, or when you take those people to the cath lab, this is what a blockage looks like. And then, when I show the pictures to the patients and their families, it's hard to kind of imagine, because what I'm really showing you is not the blockage, it's the lack of space that would have otherwise been filled by dye. And obviously this is the common carotid artery. This is the internal carotid artery. That's the external, which has branches. And then obviously it's very narrow here. The best way to imagine how much narrowing it is to try to draw the line where the normal artery would be, and you see this boulder of a plaque. And when surgeons take it out, it looks pretty ugly. So that's the atherosclerotic disease, which is the most common form we deal with in terms of causes of stroke. There's a way to say, when you see our report, 80%, 90%, etc. It's actually a calculation. It's a bit technical, but 90% is quite a bit of a blockage. A 9-10 millimeter vessel, it means there's only 1 millimeter left, patent, and the blood is kind of shooting through, trying to catch up. So when part of this goes up, it will typically affect an area where there's either a bifurcation or a sudden change in vessel size, and it gets stuck there. So the CT scans you've seen before talk about the middle cerebral artery with its being occluded. This is the middle cerebral artery, and it's cut off right there. So basically the thrombus just lodges in it. And if you want to go take it out, you have to go basically pass it, open something that looks like literally an umbrella, and then just kind of grab it back. So that's how a stroke looks like to our eyes in the cath lab. That's how we see it. Obviously, this is in a patient that came in with it. Sometimes in carotid interventions, some piece goes up and you have to go chase it and get back down. This is a picture of a carotid artery. This is the stuff that you see right here. And you know, that just tells you how meticulous of a procedure we have to do, because any of those small pieces, this in itself can cause a relatively large stroke. So the size of the middle cerebral artery, or even its branches, is so small that you only need a small embolus to cause a big problem. Kind of, you know, it depends on where it goes in the brain, but a small embolus can cause a big problem. And that is why we use what we call an embolic protection devices. Carotid disease is age-old. This is a mummy from, I think, 2500 before the Common Era. They did a CAT scan of the mummy, and you see calcium in the internal carotid artery. It is literally an age-old problem that we're dealing with. We made it worse in the modern society because of what we eat and because we don't move. You used to run after your breakfast to hunt it. Now your breakfast hunts you later on in the day. So when does a carotid blockage causes a stroke? So you know, if the patient is symptomatic, 50% blockage on an angiogram is considered important. If the patient is asymptomatic, typically 70-80% stenosis, we say 80% is what we consider important. And then there are some kind of herald symptoms. The patients that have amaurosis, which is an eye, TIA, typically their prognosis is reasonably good, but you want to use that as a red flag to go, oh, there's got to be something. So some of the referrals we get actually come after an eye exam. So a patient goes for an eye exam, they see something in their retinal artery, they say this came from somewhere, go see a cardiologist, and then you look at their carotids and sure enough, there is a blockage there. We don't always fix it. Sometimes medical therapy is just as good. Sometimes surgery is needed and sometimes a stent is needed. These are the different ways in which you could image a carotid artery, and then I brought that up to show you that ultrasound, which is a very safe, doesn't have radiation, can be done to detect carotid disease. What do? Basically, the idea from this is not to say that you do this versus that. You really do all of that. So modalities of therapy complement each other. It's not like if you can't get a stent, you get away without medical therapy. That is absolutely not true. And so medical therapy could be used as a standalone therapy, or if it's not enough, you get surgery or a stent, but in addition to medical therapy and risk factor modification. So that is something important to tell our patients is, you know, just because I fixed it doesn't mean it's completely gone. The disease process is still ongoing. I fixed the spot, and what about the rest of your blood vessels? So that's kind of more of a health advice that we keep infusing in our patients. So carotid endarterectomy is a surgery that has been going on since the 1950s, and it's a perfected procedure. It's a perfected procedure. The thing is, not everybody can have it, right? So if you have systemic disease, heart failure, you know, bad ejection fraction, angina, severe pulmonary disease, it's hard to put you under anesthesia to do carotid surgery. If you have certain anatomical factors in the neck, you know, if someone that has radical neck dissection, a trach, neck radiation for previous cancer therapy, they can't have surgery. It is very risky to open in a scar. All the nerves there are kind of stuck to the scar tissue, and it's very hard to dissect them. So then stents came around initially as an idea. It's like, why don't we put those in people who cannot have a carotid endarterectomy? And they designed a study where they took such people and split them into carotid endarterectomy or stents, and those that got a stent did much better. So death, MI, stroke 30 days later was more if you do surgery in a patient who cannot have it, right? I mean, if you do it in a person who can have it, as I said, it's a procedure that has been perfected. If someone is high risk, they don't do well with surgery, and that's where stents really kind of got their foot through the door. But then, as usual, cardiologists go, Well, this goes for high-risk people. What about moderate-risk people? What can we do for them? So then a subsequent study was done called CREST that actually showed that for standard risk people, the two procedures are roughly equal, and I say that I would like you to take that with a grain of salt. It's not like they're completely equal, like you do fine either way. The complications you take by doing surgery or carotid stents are different. But then overall in a large population, the two procedures are. So what I mean to say is there is a little more peri-procedural stroke versus less peri-procedural MI, etc. So you get a little bit of this, a little bit of that, a little bit of this, a little bit of that. So carotid stent is a good alternative, but it still has some ways to go in terms of making it as good of a procedure as carotid endarterectomy. So how about we do some case studies about carotid stents? And let me get close here. I may have to change the sequence of the pictures here. The first thing you have to do, because of that picture I showed you of the carotid artery, is you have to make sure that it doesn't have a name, that the stuff, the schmutz, that the crap that's in the plaque doesn't go up to the brain. It doesn't have a scientific name, so each one of us call it different. There are a few ways to prevent it from going up to the brain. Okay, one way is to put a filter. So if the blockage is not too narrow, you kind of go through the center and you put this umbrella, which is a filter, and if anything goes up, it'll get stuck here, and at the end of the procedure, we remove it. Another way to do it is to do a proximal occlusion device, where basically if you occlude this blood vessel and this blood vessel and you leave the catheter open, there's no way for the blood here to go up. It actually, the circle of Willis will bring it down, and it'll go down this way, and we aspirate it in a syringe and we dump it. The third way is to do distal occlusion balloon. This is an old method that we no longer use. So right now, a little over half of our procedures are done with a filter, and a little under half are done with this unique catheter. And it's all about the anatomy. So we take pictures, see how do they look like, and then basically just make the best out of it. This is what you capture in the filter on occasions. This is the clot that on the CT scan would have been kind of long, and it goes like that because it goes into two branches. So it takes the shape of the blood vessel. So had this not been captured in the filter, that patient would have not done very well, obviously. So I'll show you this. This was supposed to come one at a time. So there is somebody less cool than you, and then you can be proud. This is basically a, and I'll just kind of walk you through that a little bit at a time because this is a subtracted image, but this is the mandible. And that's the C2 is up here, and then you count from. And this is a plaque that ruptured, and it's pretty high, right? So it's behind the mandibles right here. So getting to this spot surgically is a bit difficult. It's a bit of a problem. Sometimes you have to actually cut the bone, and it becomes an extensive procedure rather. And this is the intracerebral circulation, and it's not projecting very well. But what I meant to say is that this patient has, and you see the blockage here? So try to draw the line in your mind. I mean, this whole triangle is really just a boulder of a plaque. And therefore, the pressure in this artery is very low, and the circle of Willis takes over. And then there is the anterior cerebral artery that should come up here that you can't see because it's filled with non-contrast blood from the other side of the brain. And I gotta change that. How can I show those one at a time? I can. Let me see if I can animate it really quick. This is a read-only thing. Okay. Oh, okay. They pulled in. Okay. So let me see if I can do that. Okay. So this is the filter. This doesn't project very well, but there is, you can actually see it looks almost like a small umbrella, very small, but that's the filter. And again, these are all the bones in the face of the patient, so we're kind of working behind. And that's why you see it's a lot easier to go in the groin and go this way than to try to directly get to it. But that's the filter right up here. And then this is the stent, which comes kind of crimped in before we put it in. And this is after the stent is deployed. So right here is the filter. And then this is the stent, which looks like basically a mesh of metal that's magnified. Is that a little bit clear? So then what we do with it is balloon it to kind of pop it open. Then after that, we bring this small catheter, and what it does, so imagine the filter like kind of like a cocktail umbrella, right? And it catches the stuff. Then you bring this catheter that just takes it all in, and then we drag it down and take it out of the patient. And then after that, you get a before and an after. And so this is how it used to look like with this narrow area available. And after you put the stent, it looks like a cylinder, and it all has the same color, which is really what an artery should look like. It's a hose anyway, so when you take a picture of it, the picture should look like a cylinder. So that's a before and after. So this is a gentleman that we have done on June 27th that got transferred from Heron Hospital. Dr. Ornick went to Heron Hospital to see the patient. I don't have a mobile cath lab yet either. And so I can't drive to Heron and put the stent in there, so I have to stay in Carbondale, and then the patient has to come. So this patient was transferred from Heron Hospital. He ironically was having both a heart attack and a carotid blockage at the same time, so we stented his LAD in his heart, and then we stented his carotid artery, and I just saw him in the office a while ago, and he was doing very well. So he's one of the Williamson County residents. This is before brain perfusion. This is his left middle cerebral artery. The anterior cerebral, you can't see it because there is not enough pressure in this blood vessel on the left for the dye to, the vessel is open, it's just supplied from the other side. And then when we do take the final picture, you see much more filling. That's not why we take the final picture. We take it to make sure there is nothing that got occluded in the process. And if there is, it takes then a couple of more hours to go after it and fish it out and bring it back out. This is another example of a patient who, it doesn't project very well in this picture, but he actually has a carotid stent on the other side. This is a gentleman that came with a stroke. He's a heavy smoker. He had bilateral carotid occlusion. We stented his right carotid artery, and then I sent him for an endarterectomy procedure on the left. And so the patch that you see right here is an endarterectomy patch. It's a synthetic material that when they take all the blockage out, they do the patch. Well, what he did is he kept on smoking. He actually had, he's a cancer survivor, but he never quit smoking. It's unbelievable. I think it's his level of addiction is. So, but then he comes back and something happened to the sutures at his patch. And he ruptured the plaque right there. So this is his common carotid artery. This is his endarterectomy patch. And this actually is his external carotid artery, and his internal is supposed to go that way. But he thrombosed this area, and on that checklist that Dr. Ornick showed, if you had surgery within a couple of weeks, giving TPA is probably not a good idea. And there is not much really going in his brain. I kept stepping on the pedal trying to see if he perfuses any of his intracerebral vessels, and that thin line is all I got. For a while I thought that's all he got. I mean, who keeps smoking after surviving cancer and stroke a couple of times? The other thing that it's a bit technical, but I'll show it to you. At some point in his life, he actually had to have a bear hole for a bleed. And that's the stable or whatever they used. So anyways, this gentleman obviously was in trouble, so we that's the filter again. So this right here is the filter. Does it show at least a little bit? That's how it looks like. And now this is his other carotid stent, and we're working here in this carotid now. That's the stent, new stent. The filter is still up here, and then that's his final result. So this is the patch. We stented this area, and it's wide open now. And I think I have a before and after. Yeah, so that's before, and then this is after. And you see how his internal carotid artery had very slow flow, and now it's basically going up as appropriate. So that's another way to use the stent. So I don't mean to just advertise for stents. This is a gentleman that I myself, the stent person, sent for an endarterectomy because it was more appropriate. We stented his other side when it was appropriate. Then when he came back with trouble after his surgery, it was also appropriate to stent him. So I would like to make sure I kind of give a balanced message. They complement each other. I can't say that one is better than the other. Carotid endarterectomy is a procedure that has a half a century of history. So it is still the way to go, but stents have a growing role from high risk to now in certain acute situations we can actually use them to help the patients out. That's how much perfusion you get. Even his anterior cerebral is showing up versus this after the stent. Then one more case I'd like to show you to just keep the thoughts of the non-atherosclerotic carotid disease. And for some reason, I tend to get a lot of patients from here. This is a lady, a young lady who was driving down Park Avenue and basically just went into the ditch. And she was having, when the medics arrived, she was having signs of a stroke. So the initial impression is that she had a stroke and she could not coordinate, and then she had a car accident. However, she was not aphasic, so she could understand the questions, and she basically said, no, I was fine. I basically wasn't paying attention. I knew I was going into the ditch, but the seat belt hit my neck right here. So this is a carotid seat belt injury right here. So the carotid artery should look just fine, right? And then if you look, so this is the clavicle right here. And this is literally about, I would say, 4 centimeters above the clavicle. So it's right here. Now the seat belt should not be that high, but that's what happened to her. So she had acute carotid injury because of the seat belt. I don't remember what was her SIH stroke scale, but this was a pretty bad injury for her. And she also had a little bit of hematoma in her neck, so the hematoma would compress, and it'll be hard. And she had other issues from the car accident, so sometimes you can just anticoagulate those, but if they just had an accident and trauma and a hematoma in the neck, it'd be hard to do that. So we basically took her to the lab and let's see what that is here. That's just the same, and I think this is her. Yeah. So that's after we placed the stent in it. So this is a trauma, a carotid trauma, a seat belt injury. So again, this is one situation where kind of judgment is very important. Did she have a stroke and then have a car accident, or did she have a car accident and then had a trauma? The treatment is really different, I would say. Now this is for the young person who has stroke symptoms, who you wouldn't think they should have a stroke. This is a condition called fibromuscular dysplasia. I've been in your way like all talk long, right? Give you a copy of the slide. This is a condition called fibromuscular dysplasia. It's more common in young ladies. It affects the renal arteries and it causes high blood pressure, but it affects the carotids too. Those patients have TIAs and can have strokes because of that. And so in the correct clinical scenario, when you are highly suspicious of a stroke, don't let the age or the shape or the character of the patient make you think otherwise, because it could be one of those odd things that we don't think about very often. So that's kind of all I had in the slides, and if you have any questions, I'd be happy to answer them. Yeah. So what restenosis, having a blockage back in the stent, is actually a problem for all stents. Luckily, actually, carotid stents and iliac artery stents and aortic stents perform much better than the stents in the heart. So in the past, I'd say 10 years that we've been doing this, we only had one restenosis case. So it's a single. If you read the book, it says it's less than 3%, but in real life, with adequate attention to the technique, it's very unusual to have restenosis in a carotid stent. So it does actually much better in terms of long-term outcome than the cardiac stents. And the reason is twofold. One is the blood vessel is much bigger, so a bigger stent won't block. And two, the flow in the carotid artery is actually very high, and it flows both in systole and diastole, unlike the coronary arteries which perfuse during diastole. And so the physiology is different, and stents actually do very well. The problem we had in the past is we couldn't have adequate protection from those emboli that can go up, and now those filters and flow reversal, they're getting better and better, so then the utilization of stents I perceive will go up in the future. Thank you.
Okay. So if anybody has any questions for any of the people that talk, or any of the patients, would love to help you now. Just finishing with the idea of one more time, what is the stroke network? I don't know if you saw that the two patients that we presented, we ended up transferring to Barnes. So what is the stroke network? Do you guys understand? This means that we are having computer on wheels with very strong cameras placed at emergency rooms of local hospitals. And that is the first thing. And then we're having several meetings with our stroke team and their nurses and doctors. and we are sharing our protocols. We are not replacing their protocols. We are sharing what we are doing, and we are letting each hospital adopt whatever they think will work best for their environment. And we are becoming like house staff physicians at their facility 24/7, like we will be at one of the SIH facilities. And one of our patients, our first patient, I've never met in my life. Today's the first day we met because we've seen her through the computer. We determined that she was even too sick to come to an SIH facility, and the best idea was to transfer her to Barnes. We got in touch with the stroke team at Barnes. We presented the patient to them, and that's how we did amazing record numbers as far as timing. We were evaluating her, talking to Barnes while the helicopter was landing and then taking off, and it was a situation in which all we have in mind is how to make stroke care better, faster, more advanced in whatever the patient is at. So this is when we were telling you about where to take your patient, how to organize our transport guidelines in the future. These are the hospitals that right now have 24/7 neurological care by the stroke team from SIH, which means having people like Dr. Aldalo on speed dial, which means having vascular surgeons who can do these carotid endarterectomies on speed dial, which means thinking about the patient in a comprehensive way, like the patient will be taken care of in any large city. So these are the hospitals that are right now working all together. We're only hoping that more and more hospitals will join the network. We're only hoping that, in the future when we think of our region, every hospital will be connected with a neurology stroke team that will advocate for improving guidelines, improving education, making our community aware. So we have a favor to ask you. We want you to go home today after you take one more of those brownies that are very good. And we want you to share with the people that you know that this is happening. We want everybody to become aware that if you have any of these symptoms or signs, you could be having a stroke and you should call 911. And then this is the way where neurology now will do what cardiology did many years ago, just by educating one another and getting awareness in our community. Okay? So thank you very, very much for taking your time to come here. We're available to you. We'll share our emails. We'll share the presentation with everybody who couldn't come. And we hope to meet you again in the future. All right? Well, there was an initial grant that we obtained to take care of strokes through telemedicine as part of the U.S. Department of Agriculture. And this allowed for a certain budget that allowed to purchase some machines and start in some hospitals. From now on, there's going to be a matter of wanting to participate and establishing the cost of the machine. The doctors are not charging the hospitals. So this is a matter of getting the right technology and having an internet signal. I have no idea. But we will gladly get you in touch right away with, and some people from our team will get you in touch right away. We have our telemedicine coordinator here, I believe, or she just left. Is she here? All right. So we right here have the people to get you in touch so that we can start exploring this. Absolutely. Absolutely. But I don't know how much this is you saw a picture. It's literally a computer on wheels and wireless internet, a strong camera that we can manage with our little computers anywhere we are. So we connect to that computer. The nurse puts the computer at the end of the bed, and we can move the camera. We can zoom in, zoom out. We talk, you hear. We hear what the patient is talking. And then it has some extra features that you can utilize depending on the specialty of the doctor who is consulting, like, auscultating and I don't know, some dermatology stuff that we're not using. But the point is, technology-wise, it's very simple. This is not rocket science. Yeah, it's very, very simple. But the cost, yeah, exactly. One limitation that we have is internet. Internet in a region is not among the best. So we have many situations in which we are connecting, we're seeing the patient, and we have to disconnect, turn off the computer, turn on again and connect again. This is not because the robot is dysfunctional or our computer is just the internet signal. Any other questions? All right, well, thank you everybody for coming. We're so thankful to what you do, and we hope to continue working together.
Everybody, thanks for coming. There's still food. If you want food, get it. Also, our vendor tables, don't forget about what they have over there. Check that out. And if you did not register online, be sure that you signed in, because I need your email address to get your CEUs to you. So nursing and EMS, CEUs, make sure I have